All right. So today we have Dr. Tyler Winkleman. He is from Hennepin, and we're really excited to have him talk about OUD and criminal justice involvement. It's something he knows extremely well, so it should be fun. Um, so
We have a lot of great upcoming sessions, so check those out.
yeah, a lot of fun stuff coming up. Remember that please turn on your video because Tyler would love to talk to your face and not a black box. So that'd be great if you could do that. Remember that if you want CME, which most of you do, please fill out the little thing Katie sends to you, and then you can get that back usually by Tuesday or Wednesday.
And we love to see all your faces, so if you're open to keeping your cameras on, that would be awesome. Kurt wants to check out what you're having for lunch.
Yeah, and I'm eating peppers and all kinds of things, some spinach. Remember, we're always here to help you if you need any help. You can see Erin's phone number at the bottom and mine as well. Erin's probably more likely to pick up just because she is. But if you have any questions, please feel free to reach out.
And Stratus Health is the home to the CORE website, which has a lot of really nice resources for opioid use disorder and opioid stewardship. Check it out. Don't reinvent the wheel. There's plenty of templates that you can choose from.
All right, and we will take this down and we'll let Tyler share his. If you want to just maybe introduce yourself, Tyler, and just give a little bit of a chat about what you do in real life and what you do at Hennepin Healthcare, that'd be great.
Sounds good. Well, yeah, thanks for the invitation. Looking forward to talking with you all. So I'm Tyler Winkleman. I'm a primary care physician. I came to Hennepin as a clinician researcher and worked at the Hennepin County Jail for 5 years and started the buprenorphine program there. I run a research lab called the Health, Homelessness, and Criminal Justice Lab with my colleague, Kate Vickery. And yeah, do a lot of work around the intersection of healthcare and the criminal justice system. And I'm also the division director of general internal medicine at Hennepin Healthcare, which staffs the Hennepin County Jail Clinic, our downtown clinics, and healthcare for the homeless sites. So have a little bit of a different role at the jail now, but am still quite involved in supporting our providers there and building out resources and programs. And have also started a transitions clinic called the START Initiative at Hennepin to help people who are coming out of the jail connect with primary care. So I'm going to try to I'll pull up the chat here and keep my eyes on it. I'm happy to take questions as I go. And this was actually kind of a fun set of slides to put together. A lot of my talks over the past couple of years have switched to primary care and more generally, and COVID and so forth. So I actually was able to go back to some slides I had put together a couple of years ago and update them. And unfortunately, a lot of the trends haven't changed as much as we would like. So as relevant as ever, there's also some really new policy proposals on the forefront that I'm excited to talk about at the end that potentially will make a big impact in this space. So many of the folks on this call will probably know or be familiar with some of these criminal justice stats that I'm going to provide. But I think it's really important to at least briefly review them, because I think sometimes sort of OUD and criminal justice involvement can sound like a relatively niche issue. And I think part of what I'm hoping to convey is that this is actually a much larger population and issue and problem than someone may assume at first blush. So on the left, you'll see a figure of sort of the incarcerated population over time in the United States, you can see a massive rise in the 80s and 90s to a peak in 2009 of the number of individuals incarcerated in the United States. On the right-hand side, you can see trends around the time of COVID. So while we have had some decreases in the incarceration rate since the pandemic, we're starting to see those incarceration rates go back up, and they are still at very historically high levels compared to, pre 1990s. When you compare these trends to other countries that have some similarities to the US, we're a very clear outlier. There is nowhere else in the world that has seen the level of incarceration increase like what we've seen in the United States. In Minnesota, for US states, we have a relatively low incarceration rate, still much higher than most other countries. We do have a low incarceration rate compared to other states. We have a fairly high probation rate, the fourth highest in the country. And so when you sort of look at the number of individuals under supervision of some sort, we're sort of average in the United States. And we have very large racial disparities in incarceration and probation compared to other states. These stats are a year old now, but I think likely haven't changed a whole lot. Wanted to just kind of give people a sense of the level of racial disparity that exists within the criminal justice system. So in Minnesota, Native Americans are about 1.4% of the Minnesota population, and Black citizens are 6.8% of the Minnesota population. The Shakopee Women's Prison is 22% Native American, so about 20-fold higher than the general population. Oak Park Heights men's prison is 16% Native American, and Stillwater Men's Prison, Black men are overrepresented about 8-fold compared to the Minnesota population. So when we are thinking about the population that is incarcerated, we're primarily in Minnesota talking about Black, Indigenous, and other folks of color in a very disproportionate rate. So what's increasing this? This is a slide a research coordinator of mine put together a few years ago, which I think really helps understand what's driving these massive increases in incarceration. So there's the war on drugs that started in the 70s, mandatory minimum sentences that give judges relatively little discretion, 3 strikes laws in the 90s. And there's also this sort of interesting complex relationship with the deinstitutionalization of people with mental illness, which the goal of that deinstitutionalization was to transfer people to community settings. The community resources for that never really materialized in the way people were hoping for. And so our prisons and jails have become de facto mental health institutions. Importantly, underlying many of these policies, it was often overt racism, in particular Nixon's war on drugs. And there's pretty astonishing writings about sort of how these wars were, or these policies were designed, and sort of the explicit racialization of the outcomes of those policies. So now I want to talk a little bit about the overlap of opioid use disorder specifically and criminal justice involvement in the United States. So again, this chart, not surprising to anyone on this call. We continue to have increasing overdose fatalities, largely driven by synthetic opioids in the United States. Over 100,000 individuals died in the last year from opioids. I work with a group called the Minnesota EHR Consortium. We have a public dashboard coming out in March, and some of this information will be on there. We look at rates of diagnoses and electronic health records across the state linked with different types of social determinants of health. One of the areas we look at is opioid use disorder by incarceration status. And what you can see here is that opioid use disorders are far more common among people with recent incarceration compared to individuals without recent incarceration. So 9 to 10-fold higher prevalence of opioid use disorder. This holds across racial and ethnic groups. So when you compare any group incarcerated versus not, you see much higher rates of opioid use disorder, with the highest rate being among Native Americans with recent incarceration. And that's certainly what we see in our practice at the Hennepin County Jail. This is a slide from a paper we wrote a few years ago looking at rates of opioid use compared to risk of lifetime criminal justice involvement. And as you go from left to right, you have prescription opioid use, misuse, opioid use disorder, and heroin use. And you can see that by the time someone is using heroin, over 75% of individuals will have contact with the criminal justice system. So the vast majority of people who are using heroin, we presume fentanyl as well, will come into contact with the criminal justice system. So when you think about how to approach the overdose crisis, if you are not coordinating treatment and care between healthcare and the criminal justice system, you are disrupting care for the majority of individuals with an opioid use disorder. Again, we certainly see this at the jail, and this is true in the general population of people who use opioids. Co-occurring health issues are the norm. So severe mental illness is 7 times more common. 70% of individuals who use opioids are using at least 2 or more additional substances. Disability and other physical, any type of disability is more common. Physical health conditions are also more common among people who use opioids compared to those who don't. STIs are 4 times more common, HIV 20 times more common than people who aren't using opioids. Many of you have also probably seen or heard of this paper before. This was a paper done a number of years ago by my colleague Ingrid Binswanger, who at the time was at University of Washington and now at University of Colorado. This was really the first study in the US looking at rates of death after someone leaves prison. This was in Washington State. And what Dr. Binswanger found was that the risk of death was about 13 times higher in the 2 weeks after someone leaves prison. And when they dove deeper into the findings, they found that this risk of death is primarily driven by overdose, with overdose risks of 130 times higher than in the general population. Mm-hmm. So the period immediately after incarceration is an extraordinarily risky time for individuals who use opioids, and really highlights the need for close care coordination. I can say, just this morning, I learned of a patient of mine who overdosed and died 1 day after release from jail. So this is something that bears out in the data and is a common occurrence, unfortunately, for people who work with individuals who have opioid use disorder. I showed some of this data already. This is overdose death data and there are large racial disparities in overdose deaths, with Native Americans in Minnesota having extraordinarily high rates of death, followed by Black Minnesotans and then white Minnesotans. This is a little bit of a complicated slide, but I wanted to just highlight this point and sort of, again, hammer home the point that this is not a niche population. When you look at, this was when we looked at all individuals, adult patients with Medicaid, so the biggest health insurer in the state, and we looked at patients with Medicaid who had behavioral health disorders. 2/3 of those individuals came into contact with the criminal justice system. So there is a very large focus on low-income individuals with behavioral health disorders. There's very little coordination with the criminal justice system, and it is challenging to set up programs that are going to be effective when that large proportion of individuals is interacting with other systems where they may not be getting the coordinated care that they need. And this just shows that on as sort of rates of behavioral health disorders increase, so you go from mental illness, substance use, and then both mental illness and substance use, you see rapidly rising costs across all different public sectors in terms of healthcare programs, human services, criminal justice, and housing. All right, so that's background on criminal justice trends and the overlap with opioid use disorder. Now I'll talk a little bit about treatment of opioid use disorder in jails and prisons. So as you all know, 3 medications to treat opioid use disorder. I love this figure on the right here that really shows that MOUD has a mortality benefit for years. It doesn't improve mortality for just a couple of years and then wane. When you take it and you take it for years, it continues to have benefit. What do we know about treatment in jails and prisons? Rates of MOUD in correctional settings remain low. About 19% of jails across the country will initiate MOUD. That is probably similar to what I might expect in Minnesota. Very few offer all 3 forms of medication for opioid use disorder. There was a study looking at drug courts specifically, and only 56% of drug courts offered all forms of MOUD. So even in sort of settings within the criminal justice system that are geared towards facilitating reentry and rehabilitation for folks with substance use disorders, rates of these medications can be low. I also, I think this was last week, had the opportunity to give a talk with some folks in DOJ to assistant U.S. attorneys. And the co-presenter that I presented with is a civil rights attorney in the Virginia district. And he talked a lot about how clear sort of the lawsuits and so forth have been around MOUD, and that really a number of courts at this point have determined that not allowing MOUD in jails or prisons is a violation of the Americans with Disabilities Act. There have been a number of studies, randomized controlled trials in the criminal justice system, specifically looking at opioid use disorder. And the take-homes from the existing literature, I think, are helpful. They're maybe not terribly surprising to folks in the field, but I think reinforce maybe anecdotally practitioners and patients' experience. So one, we know that individuals who are forced to withdraw in jail or prison, it reduces likelihood of treatment entry after release. So when people are treated in jail or prison, they're more likely to seek treatment afterward. There have been a number of studies looking at, is there a difference between starting medication during a period of incarceration, or is it okay to wait and then have someone follow up in the community? And the evidence is clear that starting medication during incarceration is superior to that referral. Results are generally similar for buprenorphine and methadone. And the data on naltrexone is a bit weaker. There's not as much of it. What it does seem to suggest at minimum is that naltrexone's probably effective compared to nothing, but it's likely not cost effective when you compare it to buprenorphine or methadone. So there have been now a number of national reports which our group has helped inform in various ways. This from the National Academy of Medicine, which was released now 5 years ago, had the conclusion that medication-based treatment is effective across all treatment settings studied to date, withholding or failing to have available US FDA-approved classes of medications for the treatment of opioid use disorder in any care or criminal justice setting is denying appropriate medical care. So it's sort of clear national guidance that providing these medications, not only in our clinics and in our hospitals, but also in our jails and prisons, is standard of care. There have been a number of additional guidelines published by SAMHSA, by the National Sheriff's Association, NCCHC, that suggest similar. So what happens when you act on these recommendations and provide care across the continuum? So the best example we have to date of large-scale change is from Rhode Island. It's a unique state in that its prison and jail systems, excuse me, are unified. They're operated under one umbrella statewide organization, as opposed to each county doing its own thing and then having the state prison system. So it's somewhat easier to coordinate across all of these different facilities. They implemented opioid screening and treatment in 2016, and then they looked at what happened to post-release mortality after they implemented this program and published their findings in a well-respected journal, JAMA Psychiatry. What they found was that this program reduced post-release mortality by about 60%. And this was so large that they saw the statewide overdose deaths decreased by 12%. So the entire state's overdose deaths went down because of this substantial reduction in post-release mortality. The number needed to treat to prevent one death was 11. So for every 11 patients that were treated in a prison or jail, one less death occurred. When you compare this to things like cholesterol medications, for example, we usually say you need to treat about 120 people to prevent one heart attack, non-fatal heart attack or stroke, and that would be considered highly effective. So the idea that you can treat just 11 people to prevent one fatality is quite remarkable. In Hennepin County, we've done some work also looking at the overlap of overdose deaths and criminal justice involvement. This was a report that kicked off our work at the Hennepin County Jail, where we looked at the number of overdose deaths in Minnesota after periods of incarceration. This is a busy slide. At the top in gray, the statewide, you can see there were in 2015, 2016, there were 775 opioid-related deaths, about 30%, so about 1/3 of deaths were occurring after release from prison or jail, and that was the same for Hennepin County, which was our area of interest, where we saw about 30% of individuals were dying after they leave jail or prison, and the bulk of those were after leaving the Hennepin County ADC. Interestingly, so the most deaths occurred after someone left the adult Hennepin County Detention Center, is our downtown jail. And 1 in 10 opioid deaths in the entire state were happening after someone left our jail. And so we implemented an opioid treatment program at our jail. So I hadn't pulled data on exactly what had been happening in the jail for a while. So I pulled this last night. It's a little messy, is the best I could do. But this looks at the number of buprenorphine administrations at our jail over time. So you can see in 2017, 2018, there were no buprenorphine doses administered. And last year, we had nearly 50,000 doses of buprenorphine prescribed. At any given time, it can be 15 to 20% of the jail is receiving buprenorphine for their opioid use disorder, and usually around 100, 120 patients a day. So it's a very busy service and has grown rapidly. I'd say at this point, we're sort of just barely meeting the need, and certainly have not noticed a decline at all in the severity and prevalence of opioid use disorder. This was a sort of evaluation we did looking at sort of what happened at the jail related to our opioid use disorder treatment during COVID. That was as probably we all like to want to forget, a pretty unprecedented time, and we had to change a lot of our protocols. Just draw your attention to the sort of race and ethnicity of the patients that we're serving. This is sort of pre-COVID and then right after the initial lockdown. But in both scenarios, the majority or the largest minority of patients was African American, just under 50%, and then 7 to 8% of our population is Native American. So about 8-fold higher than what we would anticipate based on demographics in Hennepin County. And then when you look at sort of who was receiving buprenorphine, we showed that in the months after, there was a much higher number of individuals receiving buprenorphine. We changed our treatment procedures to make it easier to start buprenorphine. It actually helped us determine if we could try to ensure that people weren't in withdrawal. At the time, it made it easier to understand whether they might be having symptoms of COVID or not. So sort of spurred some innovations in our delivery model, and really and rapidly increased the number of patients we were treating. So here you can see, 7.5% of the jail received buprenorphine during this immediate time period after the lockdown. I want to talk a little bit about that's kind of rapidly breezing over sort of how we run the program at the Hennepin County Jail. Happy to talk more about that afterwards. If there's sort of questions about the specifics of how we run that program. But I wanted to talk a little bit about sort of how these things are financed in jails and prisons, because it can be tricky and works very differently than financing care in the community setting. So often programs that are trying to expand MOUD rely on grants or other types of startup funds. So they can be really helpful in sort of starting the program, getting over sort of the initial implementation. But it's not an effective strategy in the long term. It's hard to continue to piece together these grants to continue a program and have the sustainability that we need for this ongoing crisis. So we started with a grant and very reasonable strategy, hard to continue a program indefinitely with that strategy. So you really need a long view of how you're going to finance these types of programs, and how are you going to expand the medical budget within that jail or prison. And as many of you likely know, the medical care that's provided in a jail or prison comes out of either county or state dollars. And so there's, as opposed to in a health system where you could maybe develop a way to bill insurance or so forth, these negotiations take place generally with the county or the state. And the funding model really ideally would meet the changing and evolving needs of people in jails and prisons, so that when we see increases in the needs for services, the funding goes up. When the need for that service goes down, the funding goes down. Most jails and prisons operate on a fixed budget, so that if you have an increase in the number of people needing services, the budget just stays flat. Some of the challenges in the financing realm are due to what's called the Medicaid inmate exclusion policy. So this is a federal law that is part of the initial passage of Medicare and Medicaid, and it bars states from receiving federal matching funds for care that's provided to individuals in jail or prison. And so the jail has no ability to, or patients in a jail or prison have no ability to use their Medicaid or Medicare to help finance their health care. And this really reduces the ability of correctional facilities to respond to public health crises. When COVID hit, there were a number of months when the medical needs increased in a correctional facility, and funding wasn't there to sort of quickly increase it. The government did eventually pass some legislation that increased those resources. But for other sort of less notable crises like the opioid crisis, the federal government hasn't been as swift to increase funding for these types of events. So there is some interest in trying to change this. For Medicaid, there is something called 1115 waivers. This allows states to modify their agreements with CMS to pilot innovations that would not typically be available under a state's regular Medicaid services. And early last year, CMS sent a letter to the directors of state Medicaid programs across the country, encouraging them to apply for 1115 waivers that would cover behavioral health services when someone was incarcerated or shortly after release. California has had their waiver accepted. Washington has had their waiver accepted. I think there's maybe one other state and then several under review. Minnesota is currently in the process of discussing a waiver to do just this. So we have an Office of Management and Budget at the state level. They're preparing estimates right now of what such a waiver would cost to provide behavioral health services during a period of incarceration. That would need approval from the state legislature. And if the state legislature approves that, then DHS would be able to apply for an 1115 reentry waiver to CMS to cover certain services during a period of incarceration. This could be a real game changer in states, in jails and prisons, offering evidence-based treatments for substance use disorders, and something that I've been closely following and talking with the state about. So 10 years ago, this was something that sort of was a proposal that got laughed out of the room and really has gained a fair amount of interest across the political spectrum. And I think it is likely to move in Minnesota, either this session or in a upcoming session. So lots happening in this space that could dramatically change how this type of behavioral healthcare is financed and supported in jails and prisons. So just a few conclusions, and then would be happy to take questions and have a conversation. So one, I think I probably said this too much, but opioid use disorder is extremely common among people with criminal justice involvement, and really will be challenging for us to fully address the opioid crisis without thinking about how people transition safely out of correctional facilities. Refusal to provide MOUD in jails and prisons is a violation of the Americans with Disabilities Act, and MOUD is the standard of care in all care settings, including jails and prisons. And there are very promising policy proposals on the horizon to stabilize the financing for OUD treatment and other behavioral health services in jails and prisons, nationally and in Minnesota. All right, so this is my contact information, and happy to, get feedback, questions, comments, concerns, frustrations, grievances.
If people want to unmute, if you have questions, you sure can. I know Aaron has questions and I have questions because we don't ever know the answers. Go ahead, Charlie.
I'll always ask. I'll always be the icebreaker. That's it was a great talk. Thank you. I had an opportunity to talk to the DEA last April, and they were actively entertaining the possibility of changing the way methadone is regulated so that carceral settings are more like hospital settings, where a prison or jail doesn't need to carry out methadone doses from a clinic. They can just continue. It would make it very easy to continue, if not start. So I don't know if you have any thoughts about if those changes happened, what the implications would be for jails and prisons, whether they would adopt it. Methadone in jails, I guess. Talk about methadones in jails and prisons.
Yeah. So when we started our buprenorphine program, it created sort of an initial dual standard where it was actually easier to treat someone if they weren't on any MOUD, or certainly if they weren't on methadone. And we had to go through a year and a half, 2 years of regulatory hurdles to finally get set up and coordinated with the Hennepin Healthcare OTP in order to continue people. So we, were operating within a system that already had an OTP 3 blocks away, in best case scenario, basically. And it's still just to set up the agreements and protocols to be able to guest dose or maintain people on methadone was extraordinarily challenging. It's interesting. I was in Ireland to give a talk with a group of people who do sort of criminal justice and health work across the world in November, and we toured a jail in Dublin. And I got to meet with their primary care provider in the prison there, and he has a little box, bunch of methadone in it that he just gives people when they come in. And he's like, yeah, we've been doing it for 70 years. And so it's very clear it can be done safely. It's very common in other parts of the world, and would make our lives much easier, but as practitioners, but more importantly, would really improve the care for people who might come into contact with the jail and or prison system. So it is possible to dose methadone in jails and prisons. It's extraordinarily administratively cumbersome, and really, you have to want to do it really badly to be able to make it work, because it's a lot of effort. So I think these types of policy proposals make a ton of sense, and in my mind, there's no question that they could be carried out in a successful and safe way.
You know, it's interesting because one of the worst calls I ever get from a small community is, we just got this guy in jail's on 100 of methadone a day. What are we supposed to do with him? And it's like, yeah, this call never happened.
Yeah.
It's like they're really, and you're right next to a methadone clinic. So,
right.
So I think that, man, those are always just a nightmare.
Sorry, Kurt. It's just really anxiety producing in rural communities when you have someone on methadone and it's a Friday night and, they've become incarcerated. It's like, what do? You just feel so stuck, because you know that no amount of withdrawal management medication like Zofran or other things is going to make them feel better. So it's just a really helpful feeling. So we've really just kind of encouraged rural communities to get a hold of their local methadone clinics and try and network and make relationships, just so there's some form of communication when that happens, because it does all the time.
Yeah.
It's just kind of a helpless feeling.
So keep me honest here. If I'm saying I'm not giving advice, I'm just, I think, stating facts, which is you can't use methadone. You can't treat opioid use disorder with methadone outside of a OTP. I'm not aware of regulations that prevent you from using methadone for the treatment of withdrawal symptoms.
Yeah, that's sometimes what I say to people, but how would I want to prescribe that and then have everybody kind of going, can you do that? And I tell people that you can use opioids for withdrawal technically. And Charlie, I don't know if you want to weigh in on that. He says no.
Without saying your name, if possible, I would just call the local DEA agents. I've done that before, and they actually answer the phone. They're law enforcement, so they're a little different mentality, but I've often called them and just said, here's my situation. And they'll give you like a really blunt answer and they are ultimately the people who are going to be deciding whether they have time or care or it's legal or not. So I'll like literally call DEA agents. If someone has OUD and is in withdrawal, it's a little, I don't know what the right word is. It's a little sneaky to say, I'm treating the withdrawal in a person with opioid use disorder, but I'm not treating opioid use disorder. You certainly can treat pain. That's a given. I think that's happening all over the place in opioid use disorder if you document it well. But to say someone's got OUD and I'm going to treat withdrawal, but I'm not treating OUD, you could try it. I personally, I have the luxury of being in an OTP, so I never have to do this. but I don't know if I would. But I'm not. And I think there is like a 3-day rule. And then the other person to contact is Moldenauer. Rick Moldenauer, the state opioid authority, also law enforcement. I think they both would be pretty helpful and blunt about not running afoul of a law or regulation. But I need reminders on this, like opioid detox rules myself. So that's my opinion. Just look before you leap.
I'm personally really annoyed by rules, but that's just me.
Tyler, that was such a great talk. In a lot of other areas of healthcare, we always get pounded into our head that we need to start the discharge planning process upon admission. So that's something that I really love chatting with jails about is, how can we do universal screening? So we're identifying folks right at the beginning so we can get them the help that they need. Can you talk a little bit about your process? Are the officers doing universal screening in their initial intake? Or is medical right there to do that for you in your jail? What does that look like?
Yeah, and I think all this is with the caveat that all of this care is being provided within a busy county jail, and nothing that I'm describing is perfect by any stretch. And so want to just say, like, these are challenging environments to work in and to try to carry out processes with fidelity. So I like to say that up front, because I think as we describe it, sometimes it sounds really amazing, but I don't want to just gloss over how challenging the work can be. But we do have like a medical intake right when someone comes into the jail. And so there are set screeners that nursing staff will go over with people from the get-go. That includes screening for a variety of different substance use. We don't screen I would say we don't necessarily screen for opioid use disorder specifically, but we do screen for opioid use and use patterns. And it's rare that we have someone where like the question of opioid use disorder is in question once they tell us a little bit about their use patterns and history. It's not usually like I'm using once every couple weeks in small amounts. It's usually for years or a decade or more in grams of heroin or fentanyl. So it's not a tough diagnosis, but we do have that screening, which has really made a big difference. I would say, so it has been largely nurse driven, the screening, and then there's a triage process that goes to a nurse care coordinator who sort of manages the opioid program, and then to our primary nurse practitioner who does a lot of the medication. We have found like that program and the process works pretty well. And then we have some people take call on weekends. But increasingly, like, our numbers have been so high and the acuity so high that we are trying to have more providers sort of down in intake and able to assist our nursing staff more, which is new for us. But we're in the process of hopefully hiring like 4 APPs to cover evenings and weekends because the severity of disease, the prevalence is just like keeps going up, and it's getting challenging for our nursing staff to make some of these decisions without sort of a provider being on site and helping out.
Tyler, I'm gonna drag you back into the gray just a little bit here. The ADA, there are some people that, however you interpret that whole situation, I have been told by people that they don't have to start. The ADA doesn't say they have to start medication, but it's illegal not to continue it. Mm-hmm. Do you interpret that the same way or differently? That there's a requirement to treat it?
I'm not an attorney, but I would say I guess what I would say is it would be in a community setting, if you make the diagnosis of opioid use disorder and refuse to connect that person to some sort of medication, sort of actively obstruct that, that would be unusual and against community standard. So I think what I would say is, I would think about it in the same way as, I guess I'd maybe just spin the question around and say, if someone has diabetes and hasn't been taking their insulin or hasn't had their blood sugar is 600, and you have a plan for them to start their insulin when they leave the jail, is that community standard?
Yeah.
And I would say that is not, no one would think, I think there's very few people who would say, yeah, we should just wait to treat their diabetes till they leave the correctional facility.
Yeah. Anybody else? Chantel? Go ahead.
Yeah, so I work at the adult correctional, the workhouses at Hennepin.
Yeah.
But in regards to it being not legal per se to not treat them, how do so many jails get away with not doing it? We transfer people all the time to other jails and they're already on. We already have them on some kind of, Suboxone, Subutex, whichever. But when we transfer them to those jails, they say we don't allow that here and they take them off of it. Or they just don't ever start it in the first place. So how are these jails being allowed to do that then?
They haven't been sued yet.
That's the $1 million question,
Honestly.
Chantel.
Honestly, yeah. I mean, that's what it is. I mean, we know from the ADA's perspective. I'm Candy Hansen with Stratus Health, by the way. I do a lot of work in jails. We happen to know that the lawsuits that are being brought up are almost, and this is anecdotally, but almost always are going in favor of the inmate. And so, I mean, eventually it's going to catch up with everyone. But as Tyler said, it's the same thing as diabetes.
Yeah, and it was interesting talking to some of the assistant U.S. attorneys within DOJ about. I mean, I kind of asked that question to have like, these are some folks who have like prosecuted certain jurisdictions around this, and as best I could tell, it's that there's just not capacity within DOJ or state prosecutor's office to like go after every single institution independently. So they've sort of strategically gone after a certain number to send a message, and then DOJ and others do provide sort of technical assistance in this space and webinars and so forth, and sort of don't have enough sticks, and so have to provide some carrots because of their resources. I will say that there will be a new statewide task force in Minnesota around opioid use disorder in correctional facilities that is coming out of the governor's office that will probably start meeting here in the next few months. And that would be a good place to think about, like, are there regulations or rules around what would be expected of a jail or prison to do this, and what type of support would facilities need who don't have experience doing this? Because I think it's a both and. I think if you immediately force people who have no experience doing this to start, it also could go poorly. So there does need to be education and support that kind of goes along with expecting places to do this as well.
Yeah,
and
one of the interesting things. Oh, go ahead.
Well, I was just to say, so things like ECHO and others could really be helpful in that manner as well.
Yeah, one of the things I've actually done with my patients who are on Suboxone, and I always say to them, if you ever, for any reason, end up in a jail and they don't give you your Suboxone, you need to remind them that there is an ADA rule that says they have to treat you. And if they don't, you should call your lawyer, right, and get on it, or call us and we'll call them. Because boy, are they sick after Suboxone after about, 3-4 days. Holy man, that's a long one and miserable. So, but I tell them that this is the law. At the minimum, they should continue it. So.
Audrey's got her hand up, Kurt.
Oh, hey, Audrey.
So, can you guys hear me?
Yep.
Okay, so I have a question about the exception for illegal drug use on the ADA. So, because that gets brought up in our facility a lot, where it's, and I'm reading it off the website right now. The ADA does not protect individuals who are currently illegally using drugs. And so a lot of my patients are obviously illegally using drugs. I guess I'm just wondering, how can that be part of the rule, but then at the same time go with everything we just talked about?
So I interpret that as when they're sitting in front of you and you're screening them, are they currently using illicit drugs? And the answer to that is no.
Like right at that minute? Like
That's how I interpret that. And that may be right, wrong, or otherwise, but that is sort of a loophole then to treat a person using risk reduction, harm reduction techniques. Like if there's methamphetamine, or like Tyler talked about, there generally is other substances in the urine that are going to be present, like meth or benzos or something. But that doesn't mean that that should be an exclusion factor to treatment of their opioid use disorder. So I interpret that as, are they using an illicit substance right at this moment when you're screening them? And then, you're essentially wanting to use the harm reduction approach and offer the life-saving medication.
Yeah. Thoughts, Tyler?
Yeah, I wouldn't necessarily weigh in on sort of the legal definitions and so forth. Definitely out of my wheelhouse, but I would just say, like, it's been adjudicated in a number of different jurisdictions, and it's been pretty clear that like a number of court cases have indicated that not providing the treatment is a violation of the ADA. So I don't know sort of the details of the legal interpretation, but those have been the outcomes of those lawsuits.
See, the way, and I've always looked at it, is that if they're in withdrawal, that's clearly not somebody who's currently using.
Yes.
Yeah. So withdrawal would tell you that that's they're not using currently.
Yeah, and you have diagnostics to back that up, like your COWS assessment. You can say how far they are into withdrawal. You're assessing that person and clearly seeing that it's been a period of time since their last use, potentially.
Any other questions for Tyler before we let him get back to his work day? I have one last question, Tyler. Has there ever been a study done that shows that treating or not treating somebody who's in withdrawal is which is more cost effective, as far as if they're sick and they're put in a special room and they're vomiting and they end up in the ER? There's often a lot of cost involved with people. I mean, I can't tell you how many people I've taken care of in the hospital from the jail, pregnant women, all kinds of stuff. I mean, that's expensive.
Well, and sending an officer with to the hospital to boot, so it causes some staffing crunches back at the jail. And then thinking about all of the withdrawal mitigation meds that you'd be giving, like Zofran, maybe clonidine, hydroxyzine, Imodium, those medications several times a day, all of those add up, so I think there is a lot of cost benefit to just offering mood.
Yeah.
Yeah. I not on cost exactly, but there have been studies that compare what are the staffing needs, and they've been able to. There have been a couple of studies, and I can try to pull them up, that show that when you treat opioid use disorder, you need less correctional staff. And so, and I would say anecdotally, at least in our jail, it's we sort of take it for granted now that there's not 80 people in opioid withdrawal every day. And job, an already hectic job, a little bit less hectic. I think there's been a number of times where we've had correctional staff say hey, come in here. I think this person has opioid withdrawal, and are sort of wanting help. So but I haven't seen something specifically, but I imagine that it would reduce cost. Like we just use straight buprenorphine. It's pretty cheap, and probably all the buprenorphine we prescribe is like 4 ED visits.
Yep, exactly. Well, and you think about justice involved individuals and how much more pleasant they're going to be if they're feeling better, and, decrease suicide risk that comes along with all of this. I mean, the benefits are definitely there. Stratus Health just did receive funding from ORAC to start a jails echo that's going to be focused on this very thing. So we're just trying to spread the word that if your county jail, your facility, wherever you are, have any interest in getting education furthered on this topic, we think it'll be a really fun project. And thanks so much for your talk, Tyler. It was just wonderful.
Yeah, thank you so much for coming, and thanks everybody else for popping in, and we will see you again. Maybe we'll bring you back in a year, Tyler, and see what else has changed. So again, appreciate your time very much.
All right. Take care.